on the Global Access to Testing Survey carried out by FIND and presented by FIND during this webinar. My name is Chase Perfect. I'm a representative in the platform of civil society and community representatives to the ACT Accelerator. In particular, my role is as a representative in the country support working group of the diagnostics pillar. For those of you who are not familiar with the ACT Accelerator or who want to know more information, I'm going to share a link to the platform website that has information about some of the structure of the civil society and community representative engagement, more information on the ACT Accelerator, and please don't hesitate to reach out. I'll include my email in the chat. Today, I'm just playing a role of introduction and a bit of moderation. So I'll be short and just wanted to highlight that, as you may have noticed, the meeting is being recorded. This will allow us to share more widely with folks who weren't able to join. But fortunately, for those of you who have joined today, there will be a question and answer opportunity. So that will come after the presentations from our colleagues at FIND. But in the meantime, of course, there's always the chat. So please don't hesitate to share perspectives, experiences, questions in the chat during the presentations, and that will enable us to exchange throughout. For housekeeping, just a reminder that if you could please keep your microphone on mute, and during the question and answer, if you do want to make an intervention, please raise your hand, and then we'll have a moderation so that we can call on you, and then that way it will make the experience more pleasant, more effective for everybody. And with that, I see that also there are lots of colleagues, francophones colleagues. Donc, je suis désolé, on n'a pas de l'interprétation pour aujourd'hui, mais si vous voulez, vous pouvez m'écrire et je peux essayer à soutenir dans la traduction des diapositives ou le partage des diapositives 3D en français. N'hésitez pas à revenir vers moi pour des questions plus spécifiques au général. Okay, thank you for attending, everybody, and I'll pass the mic to Emma Hane, the Chief Access Officer at FIND, who will give us an introduction.
Many thanks for that, Chase, and a big thanks to all of you for joining today. My job is just to provide a little context on the work we'll be presenting with you, but more importantly, I think asking for your feedback as we help refine this approach. So in general, to date, there's really no systematic data on what people think about their testing needs for COVID-19, particularly from low and middle income countries. We have a lot of data on what tests are being done, overall test positivity rates. We've come at it from a very epidemiological and technology point of view, but not necessarily from a community-driven point of view. And there's a real gap in the data regarding whether people feel they can easily and conveniently access COVID-19 testing. And that's what this work is perhaps our first stab at starting to address, but we're really hoping that we can build a stronger sort of base of evidence for a whole number of different purposes, and we'll talk a little bit more about them later, that we were keen to get your feedback on. This data is needed. It helps us very much at the global level plan and execute activities for COVID-19 testing, but also we think there's probably a lot of uses for this testing for many of you in your work with country organizations, governments and others to talk about the role of testing in the global COVID response. And just as background, so FIND, the Diagnostics Alliance, we co-convened the ACT Diagnostics pillar, and to do the work that you'll see presented today, we've worked with an organization called Premise to conduct a survey, which was really our sort of first stab at this sort of approach, which isn't widely used in the world of diagnostics and needs to be used more, to be able to ask people what they perceive their access to COVID-19 testing is. How available is it? How accessible is it for them? How convenient is it for them? Most of the material will be presented by my colleague Rashna, who's going to talk through both the methodology of the survey and some of the early findings from this sort of first pilot experiment at collecting this data. And although it's sort of a relatively small scale, it was really us testing the approach. We actually think that some of the findings are quite telling. And so we wanted to share some of those preliminary highlights from the survey with you to get your thoughts and feedback on how we can use these findings to shape our joint advocacy work at both the global level, at the regional level, at the country level, and even really at the community level. We're considering relaunching a revised version of this survey, asking ourselves questions on what topics to include, what scope to include, and we'd love your feedback there, in particular as we go through this exercise. We're working closely with a number of civil society partners within the ACT Accelerator, and I wanted to give a big thanks to Chase and to the ACT-A Civil Society and Community Representatives platform for hosting this webinar today, and a big thanks to you all in advance for your engagement and interest in this work. And with that, I'll hand over to Rashna to talk a little bit more about some of the early findings.
Many thanks for that, Emma, and many thanks to everyone for joining. Before getting started with the results, I would just want to do a quick introduction of myself. So my name is Rashna Hayat. I am a part of the ACT-A Diagnostics Pillars coordination team that's housed within FIND. It's great to meet everyone. We're very, like Emma mentioned, we're excited to share these preliminary results with you and very excited to get your perspectives and your feedback. If we move to the next slide, just to sort of double click on what Emma said, as we're all aware, testing inequity has only continued to increase. Although the number of tests globally and testing rates are improving, the equity gap remains, and there's very limited data to understand what access to testing is like in low and middle income countries. So if we move to the next slide, we'll get started talking about the survey that the Diagnostics Pillar has conducted. This survey, it was launched in around September last year. And the idea was basically to try and understand what are the access challenges related to COVID-19 within countries. The survey was conducted through an organization, like Emma mentioned. It's called Premise. Premise is basically a mobile application. It allows us to collect real-time and remote data from across the world. I'll talk a little bit about the way that it works. The way that it works is that basically Premise targets average citizens in the country of choice. They do this through advertisements, through word of mouth. Those people that they target then have to download the Premise application, fill out the survey, and they're paid a very small amount, approximately $1 for completing that survey to just incentivize them to partake in this initiative. So last year, the Diagnostics Pillar, around in the summer of last year, we finalized the survey questionnaire. We're very grateful to the CSO representatives that had provided their input. We passed on that survey to Premise, who then launched that survey through their application and targeted individuals in 10 countries. Whenever we sort of talk about collecting data, quality control is extremely important to ensure that the data collected can actually give some utility. So I'll quickly talk through some of the quality control mechanisms that are at place in Premise as well. There are a few things that they do to ensure that the data that's being collected is usable and it is of good quality. For example, to ensure that one person can only fill out one survey, because whenever you add sort of a monetary incentive, there's always a chance that an individual will try to keep filling out that survey to make some cash. So to cater to this, only one Premise account is allowed per phone, and each bank account can also only be linked to one Premise account. Additionally, there are also checks in place to make sure that the individual is within the country for which he or she is filling out the survey. These include GPS tracking and also checks for spoofer apps. If we move to the next slide, we can see that the survey was launched in September last year, and so far we've collected about 12,000 responses up till November. It was launched in 10 countries, 4 of which are upper middle income countries. These are highlighted by bolding them out at the bottom there. You'll see on the right-hand side of the slide here, the demographics of the respondents. A small caveat here, because of the way that the premise platform is built, respondents they must have a smartphone, access to internet, and be able to read and write in order to be part of this survey. So you will notice that respondents tend to skew younger and from more urban settlements, but we have a pretty even split in terms of gender here. If we talk about the survey findings on the next slide, we found that a majority of individuals, around 60% actually, reported difficulty in accessing tests. This means that in the last 3 months, they were not able to access tests at least once whenever they needed it. This finding was consistent in both upper and lower middle income countries, and it was found that there were 4 factors that were contributing the most to this low access. And these were the fact that, 1, there were just a lack of testing facilities in the area. The tests prices were extremely high. There was lack of knowledge in the public about where to get tested, but also whether they needed to get tested or not. And then it was just difficult to travel because of lack of facilities in the area. They would often have to travel large distances, and they usually did not have the transport to do so. So this basically, the survey kind of confirmed what we already knew, that despite the availability of tools at a global level, access is still a huge problem on ground. If we move to the next slide, we'll see that we also found that most testing across upper and lower middle income countries tends to still take place in more centralized settings at hospitals or isolation centers near hospitals. So a majority of testing took place at these 2 places. However, interestingly, while only 11% of tests took place in primary healthcare centers, 74% of those individuals that were tested there reported that it was extremely convenient for them to do so. So that this was the most convenient method of venue for getting tested, followed by hospitals and then workplaces. Given the latest strategy and budget, the diagnostics pillar had already planned to focus more on community-based testing and testing in community settings this year. So this finding just reaffirms that that is definitely the right direction to take. If we move to the next slide, we'll see that for now, we're planning to use findings from this survey for advocacy to inform which interventions ACT-A should support in countries. We potentially want to provide this information directly to country governments to help them make decisions on resource mobilization, and also plan to include findings from this to help build the ACT-A comms toolkit. However, in its current form, like I mentioned, the survey is only sort of confirming what we already know. So there is a plan to extend this survey. We're planning to amend it in order to better gauge the feasibility, the accessibility, the acceptability, and affordability of COVID-19 testing, in hopes that this can help, such data can help inform public health decision-making at the global level. I think that's it for the presentation today. It would be great to get your reflections, your perspectives on next steps, and I'll hand it back to Emma for that discussion.
Wonderful. Many thanks, Rachna. So we're really looking to all of you for your thoughts. I think There's a lot of different ways that we can take these questions. There's questions around how do we best use the data we have in hand? And we'd love to hear from you, like what shape is the data that we already have for you most useful in a lot of your work in countries? The second set of questions is around what should we take from here in terms of this survey? So how should we evolve this? What are questions that we didn't collect data on that we should be asking? Obviously, we were somewhat selective in the geographies that we included and the countries that we included. A lot of that was because we were doing some similar survey work elsewhere in FIND and were so able to use it to triangulate whether we were getting good data via the Premise platform, but not necessarily coming at it from the lens of where do we most strategically need this data to be able to help efforts like yours. And then my third set of questions are really around what other sources of data and insights would complement this kind of work. This is obviously an effort that's driven at a pretty global level. We think it could be complemented with a lot more community-driven efforts, including more community-based monitoring efforts and similar. And so it'd be great to hear from you on what some of those might be, just to name a few. There's a few questions in the chat as well. So Rachna, did you want to take the question on the results per country and what we can share there? And then perhaps I might touch on some of the questions on price versus distance. Amit's question is really, how do we get a country specific breakdown to understand the different drivers?
Sure. On the country-specific breakdown, so we're planning to relaunch the survey next month, and we'll have findings, country-specific findings shortly after, and we can share that. I think a reasonable timeline would be end of March, beginning April for country-specific findings. Super.
Mit, a question for you, and do feel free to jump in or write it in the chat. What form would the country-specific guide data be most useful? Is it helpful in slides? Is the comparison helpful? Would it be more useful as a one-pager? What's the most useful format?
Well, I think my question was in the sense of, what is the diagnosis of the problems, of the barriers per country? Because otherwise difficult to, on base of this generalized, averaging out certain things, and to see if it's really then the price that's blocking or the rural areas, it's a different situation. I'm trying to link it to what were, what is the relative importance of the barrier, and also linked to what as a cause that it was, in order to construct in the other way.
I get you. And Rachna, if I remember right, we have a drop-down list that people can choose which are the barriers against, right? It's not free text. And so perhaps we even need to refine that list with the help of this group as to whether we're really collecting a good, useful and the right set of potential barriers for access to testing. Well, ladies, jumped a couple of questions into the chat on forms of testing, whether it was PCR or rapid tests, and we didn't ask people to differentiate. People sometimes can definitely tell the difference, sometimes can't. So we didn't ask people the different sorts of testing necessarily, but it might be something that we could see if we could tease apart in sort of future surveys, and something that community-based monitoring might be quite effective to identify. Farmers also asked a question on sample size and country selection criteria. I might briefly answer on country selection criteria, and then I might hand over to Rachna to talk a little bit about what the broad sample sizes were that we got, because they were quite large sample sizes really that were taken. So the countries were identified, having a look at countries where actually the largest number were where we were doing some qualitative surveys and interviews, on some very similar set of questions as part of our market research for the launch of more self-testing products that were appropriate for low middle income countries. And so those surveys, which are done off a much longer timeline and are done for the sake of informing WHO guidelines and other sources, were a helpful triangulation point for us when it came to these data. So the countries were selected non-randomly in order to be able to triangulate with those other data sources. And so you might notice that that's, as a result, the countries tend to lean towards low middle income countries than low income countries, for example, tend to weigh towards some of the larger countries than others. Fatima asks a good question on what other barriers could be explored. And this would be a question, actually, Fatima, I would love to ask this back to you. What are the other barriers that we should ask for that we didn't ask for? And maybe, if it's okay, Rashna, at some point that we could drop in the chat the list of the barriers that we did ask, so that people can see that and spot some of the obvious gaps. Does that sound good?
Yeah, sure. I was just adding that now.
Wonderful. Let me hand over to Sarita, who's got a question, and then I'll come back into the chat. And it's possible if I've missed any in the chat, by the way, as I go, because I've been scrolling poorly, I apologize. Sarita, do come on in. Sarita, you're on mute. I don't know if you're talking at the moment or if you can hear me okay. Perhaps, I'm not sure, while Sarita's coming off mute, perhaps I can hand over to Gladness. Gladness, did you want to come in here? There we go, you're on mute still. I'm so sorry, we can't hear you at the moment. Perfect.
Okay, perfect. Oh, thank you. I'm very happy to be in this forum, and thank you for the introduction that we have been given by Rashna. And I just want to know, I'm from East Africa and Tanzania particularly. I'm the coordinator for Crisis Resolving Center. I just want to know this study of testing and COVID-19 in Africa. Which countries this study have been particularly done? In which countries? I know we have East, South Africa, West Africa, Central Africa, North Africa, etc., etc. So I'd like to know which countries or sampling of the countries that the study have been done. Thank you.
It's a good question, Gladness. What we might do is we might pull up the map again that has the countries highlighted. From memory, it was Kenya was included, but not Tanzania. And it'd be good to get a sense from you. Would it be helpful to get a similar data set from Tanzania? And if so, you know, is there any sort of modifications you would look to on the kind of questions that we were asking to more be useful for you in the context of your work in Tanzania? Are we able to pull that map back up, Rashna? I'm sorry, I know I'm asking you multiple things at once. I can also do it. I just have to find it at hand. Oh, here we go.
No, thank you so much. Thank you so much. I think at this juncture, okay, the map is there. I think by this juncture, it will be good to get to know even in Tanzania, and it will be agree to volunteer to work on that.
That's good to hear, Gladness. We'll sign you up for it.
Thank you.
Let me check if Sarita is able to come off mute yet. Otherwise, I might answer a couple of other questions that are in the chat.
Okay, thank you.
Thank you, Gladness.
Thank you.
I think, Sarita, we can't hear you, so if you do hear me, just feel free to come off chat anytime and let me know, off mute and interrupt. Matthew asked the question on definition of need. And so perhaps I might hand over to Rashna to talk a little bit about how that question was constructed. I would say, Matthew, overall, before I do hand to Rashna, we asked it in a pretty conservative way. So what you're seeing when you see that sort of 50% of people are able to access testing when you need it is, that's almost under the best case for access to testing. We asked a population which skews a bit urban, skews a bit young, skews a little bit middle class, and we still only saw that sort of 50% access amongst those who had a reason to need to go to get a test and felt that they needed to get tested. So it really is a sort of pure access question. Let me hand over to Rashna to talk a little bit more about how that question was constructed, though.
Sure, Emma, thanks for that. So the question was basically phrased as whether they needed, it wasn't for a specific reason. So it wasn't testing for work-related purposes or testing for travel-related purposes. It was just whether they felt they needed to get a COVID test and were not able to find one. This could be for travel, for work, because they have symptoms, etc. But going forward, we did feel that the question was a bit vague. So we are thinking of rephrasing that and would be happy to. Sorry, I was muted.
Go ahead, Rashna.
Yeah, I was just saying we would be happy to get your feedback on that. And I saw another comment by Charles on whether we mind sharing the survey questions. Sure, we can share those as well.
Perfect. I don't know if they're at hand. We can even drop them into the chat as an attachment or something for folks to look at, or we might call on Chase and others to share via the chat. Just a few other questions that are in the chat, and I see the question from Sarita in here, which is super helpful, which is on accommodation being made during data collection, which is a really good point, Sarita. And as I said, this is a relatively specific cut of the population that we're taking. So these are people who have a smartphone and have signed up to the Premise app. What I'd love to hear about, and you might have some thoughts here, is what are some other forms of data collection that we can do with communities, especially those for whom these sorts of surveys and this sort of approach are going to systematically miss, to be able to make sure that their voices become part of this effort. So what sort of kind of more community-based monitoring, whether it's community-based surveys, can we use to complement this so that we're able to provide a sort of a broader picture, especially in our global advocacy work, but also for the work at country level as well. So that's one question that you had there, which I think is a really excellent one. Let me hand over to Mary for her questions, and I'm also going to pick up a few more from the chat after that.
Good afternoon. My name is Mary from Kenya. I am from Kanko. Kanko is a Kenya AIDS NGO consortium. Can you hear me?
Yes, we can hear you.
Yes. So I agree with the findings of the survey, and I think there's still lack of access to the testing. In my country, I'm glad that Kenya was one of the countries where the survey was done. And I agree that lack of access. In Kenya, the testing is still very costly. Majority of people cannot afford it. Apart from that, the testing facilities are very sparse. People have to go long distances looking for these testing facilities. The type of testing, we do the PCR antibody tests, but the rapid testing, which I think would be rolled out to the communities, is still not really available. I've not seen it myself. I've not even heard of it being done in Kenya. Maybe it's done. But I think we should improve this access. We should advocate for more testing facilities, expanding the testing facilities, expanding the availability of tests, the tests themselves, the laboratories, the testing kits. We don't have enough. I know there are, but we still need quite a large number of testing kits so that it can be expanded to the communities. So part of the question that I think should be asked is, Do the communities have the testing? They don't have the testing facilities. Do they even have access? Do they even know where it is? They don't know where it is. I think many of the people who are tested are those who go to hospital because they are sick. And those who are not sick basically do not know that, okay, would I just go for testing if I feel like I want to know whether I am COVID infected or not? So in my thinking, a lot more need to be done so that equitable access to testing facilities can be available in the low and middle income countries. And these would involve a lot. We as the civil society organizations, we do a lot of advocacy on this. We do engage with policymakers. We do community awareness creation. And I think probably we can hear from other countries to see what happens in their countries. Thank you so much.
That's really helpful, Mary. I think one of the things when we had to look at the data was we aggregated up to the country level. And so it doesn't show some of the gaps at a subnational level that are so critically important, particularly at like testing right down to the community level, as you allude to. And so perhaps after sort of Kenya being one of the first countries that we've done this in, we could think, and maybe it'd be something we could talk to you further about, is how do we then get perhaps more of a view at the provincial level, or more of a view for, say, rural communities versus urban communities, to pick up that differential in access that we suspect is there, because we can see that testing is quite concentrated in Kenya in these testing sites in urban areas. And so that sort of implies that there's some significant gaps in access. There's a few questions in the chat. Thaddy points to this great point around what about cultural factors, like sort of religious beliefs or others that could be playing into this. And I think that's a really good question. I don't think this survey has been designed to really pick up all of the internal reasons or thoughts and perceptions and beliefs about testing. But I did wonder if there may be some complementary work that we could do, particularly some qualitative interviews and others, to really uncover a little bit more about this, both for communities and individuals. It'd also be interesting to hear from healthcare workers, their perception of testing, because they obviously, interact a lot with communities and sort of pass on some of that specific stuff as well. And so I think that could be sort of very interesting. I'm just going through the chat, Rashna. I don't know if there's other questions. I'm a few questions behind that you would pick up from the chat that we should definitely answer. Roger's asked a question on whether this is people who are tested who are not vaccinated or not. So the survey data that you saw was from late last year. And so in the majority of countries that we'd shown, vaccination coverage rates were pretty low at that time. But it's an interesting question, and we might be able to, as time goes on in the next rounds of this survey, to be able to distinguish, is there a change in access or perception around testing as vaccines roll out? It'd be very interesting. Chase asked a question on whether governments are doing their own evaluations on access to testing. Chase, none that I've come across. And if anybody knows examples where people are taking a strong access lens and looking at, for example, what rated number of communities are covered well by testing, that would be really great to hear. The only data point that I know of is some facility surveys that have been done by the Global Fund and others. So if there are other examples here, I think that would be really fantastic. Let me hand over to Bijou perhaps to ask a question or a comment.
No, hiya, I'm Bijou. Sorry, mine's gonna be a very quick, short question, because I've just seen the map, but I haven't seen any country representing like the Central Africa, because myself, I'm from Central Africa. I haven't seen any sample at all from Central Africa. Is there any reason for that?
Miyu, it was entirely that largely the countries that we're done with, these countries that we're also doing some other self-testing work in. So I think it would be really important. You'll see like a general lack of Francophone countries, I think, across the board in this survey. There are some Portuguese speaking countries that were included, but relatively few Francophone. And I think that would be really important to include in the next phase. Premise has some reach through parts of Central Africa and West Africa, not every country, but I know, for example, certainly DRC is a country that they do have an existing network in that we can use to be able to fill some of those gaps. I think they're absolutely true. Let me hand over, I'm not sure whose name it is, but the Association of Youth Change.
Hi, my name is Khawla. Can you hear me?
Yes, we can hear you.
Okay, my name is Khawla. I'm a member of Youth Change organization. We applied in the last proposal. So I have a question concerning this survey. You said that this survey in Tunisia, that you used phones. Yani asking people using phones.
Yes, so we know that it is then a slightly biased sample. So what we might do is pull up the slide that gives a bit of an epidemiological breakdown. So you'll see it slightly favors urban populations and slightly favors younger populations.
Okay, so the problem is that there is some people, especially in rural areas, that they don't have phones. So how could you collect that data? I don't know, because rural areas have no access to testing. And the most problem is there. So how could you know that the data you collected is what is going on? And I have another question. Well, it's not a kind of question, but it's a proposal. You said that if you have any ideas about other data collections. So I think that talking to people in real life is way better, because there's some people that don't have internet or access to phones, smartphones, things like that. So I think that if we talk to people in real life, so we could have great answer or better data, I guess.
100% agree with you on both points. So we know that this data then skews urban. It tends to skew, so not quite for the poorest of the poor who don't have phones, not for the wealthiest who don't need to make a little money by doing surveys. It's that middle group.
I know that. That's not my point.
What's most useful about it is the immediate feedback of data. So that's what's sort of valuable on it. But I think it needs to be complemented with, as you said, deeper direct data that comes directly from communities. And it would be great to hear from this group, how do we collect that to be able to complement this data? Because it would be really great to be able to show those two data sources together to say, this is our kind of collective view from communities. In some ways, we've got a best case scenario, which is amongst those who should be able to find a test because of their demographics. Even only half of them are able to get a test when needed. If you look at those for whom access is difficult in the health system in general, it's even worse. That would be, one can imagine that that's sort of like a powerful story to be able to tell from an advocacy perspective.
Okay, I understand. Thank you so much.
But any thoughts on kind of methodology, approach, volunteers to help collect this data? We're very, very keen to do so. Let me hand over to Koga. Apologies if I've mispronounced Koga.
It's okay. Thank you so much.
Thanks, Hala.
Hello, how are you, everyone?
Very well.
My name is Koga from Tanzania. Working with the Tanzania Council for Social Development. I'm interested to know when you were doing your survey, to what extent did you meet the issue of inaccessibility to COVID-19 testing considering my country whereby there is a limited COVID-19 testing facility. I don't know what has happened in Kenya to consider local community who usually have their health services, say like 10 kilometers away from their home. If you had a sample on that particular remote area. Thank you.
I think it's a really good point. I think in many ways, this is our sort of first stab at moving from just focusing on the technology and the epidemiology to getting some community data. I don't think it is wholly on its own adequate. And I think as we've heard about in countries like Tunisia, it's going to miss some of those populations. I think Matthew in the chat and others have pointed to this in terms of like, can we get some additional data points to be able to triangulate this? Others have talked about how we could get more perception data. So how do people feel about testing? Are there cultural factors or religious factors or others that tie into how people perceive testing? And I think I'd love to hear more from this group if there's any thoughts about how do we sort of kick off starting to collect exactly that data, because I think that helps provide a wider lens than this first initial quite narrow one. Let me hand over to Chase.
Hi, yeah, thanks. And just the presentation has been really interesting to feed a lot of the brainstorming as well about how some of these issues of access to testing, whether they align with some of the challenges being experienced in other countries or and across other diseases, and the triangulation of that, not just across diseases, but also kind of the different approaches that countries are taking to their laboratory systems and whatnot. So, I mean, I had the same impression during the call, during the briefing on values and preferences, but like, I think this area of both values and preferences and evaluating access to diagnostics, and then the third part of like, how is that information then being translated into improved policy, is like super needed in the diagnostic space. And I think it's really interesting to see how like each iteration of it in any given disease can both be improved, but also kind of connected with other diseases. And I think that it like would be very interesting to see if there's a way to like bring in some sort of working group of civil society in a longer term process of kind of like how does civil society contribute to the processes as they have in this process, which it's been great, but kind of normalizing that and also figuring out how to translate that to impact in the advocacy. And this is you know, the work that's being done with COVID is a perfect example of the kinds of activities to do. And then of course there will be lessons learned at each step. And I'm just thinking about identifying how to make sure that things aren't done in silos across diseases, and that that there's some long-term vision of building on each survey that's done, and trying to figure out how to make those tools more impactful. Because I mean, we can have we have the issue of getting the best data possible, and then how do we make sure that the best data possible is being translated to the best advocacy possible. I think those are two kind of related objectives, and super awesome that FIND is taking this forward, and also in the process of really integrating a lot of civil society community voices. And it just really confirms, I think, the need to build this out more, in a longer term way and comprehensive way.
100% Chase. And I also think, you know, I'm being a little selfish, which is that in the diagnostic space, it's largely been very much driven by technical experts, right, and others. So there's been a lot of time worrying about sensitivity and specificity and all these test performance characteristics. And nowhere have I ever really seen much work about how do people perceive tests, right, which are really an important factor. People go into a health center or a clinic not knowing what their status is, but being worried and concerned that they might have COVID or might have another disease, and they come out with some more information. That's what the test provides. And that's a really important interaction between communities and testing that we've never really collected in other diseases. And so can we start doing that in COVID and take some of those lessons sort of through to other diseases as well? That's a little bit my selfish goals here on behalf of FIND. Let me hand over to Fama, and then we're going to try again, Sarita. I'm hoping that we might have fixed some of the audio pieces. If not, I will answer the question that you dropped into the chat, but let me hand over to Fama first. Oh, Fama, you're still on mute. Apologies if I'm mispronouncing.
Is it okay now?
Yes, we can hear you.
Good. I do appreciate that the survey were done, and I think this is an attempt and it needs to be improved. So far we had issue. You already told me that the sampling was not randomly, and this was a major concern regarding the result, which will be an outcome. But still, as you wanted to have some more input regarding indicators, I think in order to have a proper outcome or result, we need to compare rural access versus urban access. So those two indicators, wherever you will be talking to people, it will be very good to know this person is speaking from town or is speaking from a rural area. They are in Africa, especially faith-based resistance to whatever is related to COVID. And I think you should need to know which faith has this person. Is it Muslim? Is it Christian? Or it's non-believers' opinion? This kind of indicator will still clarify which kind of resistance we are facing. But still, when we are talking of this test, there is issue regarding travelers and non-travelers. So these also should be among the parameters you are going to talk to people as you are discussing the survey. I mean, urban versus rural, faith-based opinion, then traveler and non-travelers. When you want to hear regarding the use of how to engage decision maker, I think we need a broad study, especially most of the country you talked, you've seen they are in the south of the world, which is a poverty background in general, no matter where we are, either in America or in Africa or in Asia. So the issue is when you look to the general budget of those countries, the concern starts which proportion of the budget is affected to the health. And if we are discussing the access, then I think access should be distributed into the different component of it. First major barrier to access when it comes for Congo is actually faith-based resistance. People are considering COVID more into business than the rest. When you go to the next step is financial access. It's not understandable that the same test costs $5 for a pedestrian, it costs $30 for someone flying, it becomes $60 for someone because he's just a foreigner. So it's no longer a medical test, it's more a business related test. The last point I would like to know before we engage actually leader is to set a standard, and probably WHO and other civilian society actors like we should stand and fit a standard of access and make sure that this test remain either medical or it become more of business test. Thank you.
That's really helpful. Many thanks, Fama. And actually, Fatima mentioned the same thing around beliefs in the test and how do we start collecting that. And I think that's going to have to be complementary strategies for data collection here and be able to feed it in. And I think your thoughts are collectively on how to do that well will be really helpful. And what I might do is just see if we've fixed the audio problems for Sarita. Sarita, do you want to try coming off mute if we've now fixed it? And if we haven't, I'll paraphrase the question you dropped in the chat.
Can you hear me?
We can hear you. Great.
Okay. Okay, thank you so much. First of all, for the great finding. Just I want to just raise the two questions, and then I want to make for the collective strategy. I would like to highlight the another point as well as. First thing is, how do you consider or how do you manage the intersectionality within a data collection? Because you know that you already mentioned in the you reach in the rural area, but you use the tool which is related to mobile phone. And then second thing is, you know, in the case of the diversity within a disability, sometimes it's difficult to have access with the intellectual disability, deafblind, and kind of people who are in the severe disability. How do you did you use any specific tool and technique to identify the real situation within the intersectionality of the disability and the intersectionality itself from the marginalized community? Yes, those are my questions. Then I think for the finding of the survey, I think we need to share in the larger network, and then as well as maybe the some practical need to have a campaign to replicate some practical strategy which are already utilized in the area where research was done. Yeah, thank you so much.
Many thanks, Sarita, and it's a really valuable point. In many ways, the survey results are the best case scenario for countries. So what we're saying is that in the best case for people who absolutely should be able to access a test and everything is in their favor, only half of them could still access a test. We know that amongst the kind of groups that you've referred to, it's inevitably going to be worse. And I think your help and others' help in thinking through how do we start collecting that data, it's probably not going to be the same methodology, right, in order to be able to access it from groups who are much more marginalized, who struggle to be able to access the health system for other conditions. How do we start collecting that feedback and being able to feed that in? Obviously, we have an interest at the global level, but also through to more community, local and country-based decision-making and policy-making too. I think any thoughts on what complementary strategies can be used there will be really important. Let me hand over to oh, sorry, go ahead, Sarita.
Just I would like to one add thing. I think it might be helpful, you know, the International Disability Alliance, IDA, in Kathmandu University, and as well as the University of the London. I forgot the name of the university. They jointly developed some tool and technique to how to identify or do how to do research with the intellectual disability, and they already developed some practical tool. Maybe that also we can reflect in further further advocacy strategy and further research time as well as. I think so. Just for the highlight and just for the information. Thank you.
Absolutely, many thanks. And if you find that link or anything, do feel free to drop it in the chat, and we can. I think this is obviously the first of a number of conversations on this topic. Okay. Let me hand over.
It will be get if I get the email ID, then I can send that link by tomorrow, because so far I don't have, but I can share by tomorrow.
Wonderful. We'll drop it in the chat so you can cut and paste it.
Okay. Thank you.
Let me hand over to Caroline.
Thank you so much, Emma. First of all, thanks to FIND for actually doing this research to actually demonstrate the difficulties in accessing COVID diagnostic tools. And while you acknowledge all the limitations, I think it's really important that we have this data, because we know it from on the ground that this at least has 12,000 respondents in a supposedly economic, at least a little bit advantaged situation of having a phone, being able to respond to a survey and say they cannot get a test. And that's critical. One of the things I would ask as you move forward with the surveys is that you start to look at a lot of the factors that have been raised here, how do we reach and really ensure those at the last mile are the ones that we reach in our survey. But what are there attitudes to, would the need for a test change if there was a perception of something you could do with the test afterwards that was positive? So in other words, people may not even want a test, much less need one, because all they see behind a positive result is loss of work, challenges, a whole series of things, which might be different if a positive test resulted in some practical help, whether it be treatment, So would there be any change is one of the things I think that I certainly we would be very interested in understanding. You'd think it would, because it certainly did in HIV. If people could get a positive HIV test and get treatment, they were much more likely to take a positive an HIV test. But it'd be interesting to see it as a balancing around.
100% agree, Carolyn. And as you know, the only reason I sometimes push back on it in the global narrative is I don't want us to give excuses for low testing to like the lack of treatment options, right? That we need to continue to push for more testing, but it's, it is a legitimate sort of response and perception from people. And it'd be really interesting to know for COVID and acute disease, where perhaps there is this benefit in terms of being able to protect your family from catching COVID if you know that you've got it. Does that translate differently than HIV? I'd be really interested. I have no idea. Again, it speaks to that lack of data on how people feel about testing. That is, a gap across the board in not just COVID, but other diseases. Let me hand over to Rogers for the last word before we do a quick wrap up.
Thank you very much, Hannah. It's a pleasure from Cameroon. We are here as a team, the grant office from Cameroon, and we are so pleased to join you this afternoon, and we really much appreciate the research you've done so far. I don't know what obtains back in Europe and in other African countries, but when we look at our context here, we've come to the realization that low testing has been plenty because of the perception and the mentality of many of Cameroonians and Africans at large, because the outbreak of COVID-19 came with this fear, and so many persons thought it was something that is foreign. And because we had the news that came to us, like it does not hit the Black person or someone with dark skin and stuff like that. And when it came to Cameroon, sometimes some years back, we had a lot of issues around it because our people felt that it was a political kind of something, that it was some manipulated illness that was coming from somewhere. And all of these things put together made people run away from testing. And so Cameroon does not really face an issue of testing stations because the government is doing a lot to put a testing station everywhere so that everyone gets tested. But because of that mentality, that misconception, that misinformation about the illness and what surrounds the illness, the pandemic, I beg your pardon, so many persons fear to even go to the hospital for testing. In fact, people do not even go to the hospital because it is alleged that when you go to the hospital, you're going to be given COVID. And so a recommendation from our end is that if we could talk more about the mentality, the change of the misinformation that is coming from different sources, if WHO could actually hammer hard on the right source of information to persons, especially to this other end of the war, I think testing is going to be of really no issue. But before I end this afternoon, we also had this issue. When we test and we find positive, just like Ms. Gomez or Madame Gomez was talking a while ago, what do we do with these positive cases? Because we've discovered that fine, it's so much concentrated on testing. We would test, and the obvious truth about it is that we are going to find some positive. What do we do with these positive cases? Do we just test and then we get to this point, we say, oh, we are sorry, our answer.
Rogers, I think you've frozen for me. Have you frozen for others, or is it my connection?
General freeze.
Oh, sorry, Rogers, we've lost you, but I think it was an excellent point that you were making on, again, coming back to, I think what to me is one of the big sums and takeaways from this call, which is how do we get more into people's minds on their perception of testing? And I think that's work that this methodology won't get to. I think we need to do some complementary pieces to be able to really pull in that sort of piece around perceptions, cultural factors, and other things that are driving how people see testing. And I think any sort of thoughts in this group, and perhaps we could have even further conversations along those lines, I think are really valuable.
I think Rogers is just trying to connect because we are working as a team. So he's
oh, no problem, Jeremiah. I think I definitely got the key message there, Rogers. I'm sorry about that. I was just summarizing what I caught from you in terms of like how people perceive testing and how we need to start, I think, being more systematic in how we collect some of that more qualitative and perception data for people, because that really is important for feeding into the policy making process, which is really excellent. I think someone made this comment in the chat, and I would 100% agree. As we think about expanding this testing survey on people's access to testing, it really needs to be in collaboration with community groups in country, especially for both targeting the work to collect the data, but also in being able to pick up and use this data to be able to help in advocacy and government engagement, other pieces which really help us to be able to drive wider access to testing. So that's just a few of the points. We're going to keep the chat, and we might come back to you on some specific questions. I know one thing we didn't touch on so much was how do we use this data from an advocacy perspective more, and so perhaps that's a topic for another conversation. But perhaps I'll hand over to Chase. Chase, are you ending our call today? I don't have the agenda in front of us. I'm so sorry.
No, that's fine. I'll be brief because I know others have to join on other calls. First of all, thank you, Emma, and thank you, Find, for the initiative on this and for sharing today. Just to quickly add to that last point, I think it'd be interesting to continue offline the conversation and discuss maybe how community-led monitoring, some of the work that's being done, particularly on HIV that's being financed through PEPFAR, provides a really interesting model for some of this work to provide structured qualitative data on the ground that also adds both structure and opportunity for collecting more anecdotal information that can be very powerful to the advocacy as well. So that's definitely something to explore, discuss, and there's definitely precedent developing with the work being done and being financed through PEPFAR right now. So thank you to everybody. I highlighted in the chat the link for information on the platform of community and civil society representatives to ACT-A. Please don't hesitate to reach out with questions, information, to share experiences. And lastly, also shared the link to the white paper on test and treat. Something we didn't discuss extensively today, but we did do a 2-hour webinar, hour and a half webinar on last week, and that recording will be shared. If you weren't part of it, please reach out to me, and I can be sure to add you to the list of people that we're sharing the recording with, because of course the emergence of antivirals and potentially scalable treatments would change lots of elements of the testing equation and to the potential demand for testing. So thank you again, and right, have a nice, we're Wednesday, right? Have a nice Wednesday.
Thank you so much, all.